Good evening, everybody, and welcome to Prostate Forum's presentation on Discover Your Radiation Toxicity Risk with ProstoX. We're going to go cutting edge here tonight with a diagnostic tool that looks at your microRNA to see your toxicity risk for radiation treatment, be it SBRT or IMRT. And we are privileged here to have Dr. Joanne Weidhaas, MD, PhD, and MSM, which is a Master's of Science in Medicine.
Actually, management, strangely. I did a year of
it's a management degree.
Yeah.
Oh, excellent. That's Dr. Metzger, too. And with this, we're going to have an opportunity to get into personalized medicine that is going to let you determine what kind of radiation is best for you to avoid side effects and what kind of side effects you might be at risk for. Miradex is an interesting company in that they are not just researching variants on prostate cancer. There are other kinds of cancers they're looking at too. And I hope you'll elaborate, doctor, that will allow us to develop individualized treatments with other cancers. Dr. Weidhaas leads translational research in radiation oncology at the David Geffen School of Medicine at UCLA. She co-discovered the KRAS variant, a predictor of cancer risk and treatment response. She has founded Miradex and something called Mirikine to provide meaningful health information, completed her oncology training at Memorial Sloan Kettering Cancer Center in New York. She is the former chief of breast cancer radiation services at Yale University Cancer Center, earned her MSM from Stanford University during a Yale sabbatical, and joined UCLA as professor and division head of translational research in 2014. We've got a lot of vocabulary tonight, doctor, everything from what's translational research and what do we talk about with microRNA.
Yep.
So I'll stop sharing, let you put up your slides.
All right.
And
so
then
much to talk about. Thank you for the introduction. Thanks for the opportunity to meet with you all and chat and answer any questions and expand scientific understanding about what's coming. So I'll tell you the kind of the story of what is behind ProstoX, how we got here, and what it's about with a relatively short slide deck. But again, feel free just to holler out since I can't see you all if anyone has a question. As you heard from my background, I'm a radiation oncologist and a scientist. I did a PhD in molecular biology and was always very interested in genetics. So like how the instructions that we have in all our cells and our DNA, because what was very obvious to me, particularly during residency at Sloan Kettering, was that you could treat people exactly the same and they could have very different results or responses to that treatment. And in cancer, we have focused so much on someone's tumor, their cancer type, prostate cancer, the Gleason, all those things. But we'd never really been able to add the patient into the patient information into response to treatment and selecting treatment. And I really felt like that was not, I'd say a disservice, but we just didn't have the tools to do it. So I'm going to tell you about some new discoveries that are helping us do that and some of the ways we're using them. Oops, if I can get my slides to work. Okay. So who we are, you already heard who I am. And my co-founder, Miradex, is actually, his name is Frank Slack. He and I were at Yale together. Strangely, we did our PhDs across the hall from each other when we were both at Tufts in the 90s. And when I went to Yale in 2004 as junior faculty, Frank was a very successful scientist and discovered an example of this new understanding of genetics, which I'll talk about. And he is a developmental biologist, as that is where these discoveries were made, and really wanted to move them into cancer. So we partnered together and found some interesting and exciting things that we've been offering to patients. And as you mentioned, we have a unusual model. We founded MiraDX in 2008. And at that point, we had made our first discovery. And we really, Frank and I both wanted to find the best way to use it to help the most people. I then realized how really complicated and confusing the diagnostic company model is. I really understood that. I took a leave to go to business school because I'm like, why is it so hard? We really just wanted to get meaningful information to patients. At that point, I realized that actually I really maybe should have just started a nonprofit because my interest truly was really just helping patients. So we spun out a nonprofit. I founded a nonprofit called MiraKind. And the purpose of MiraKind is to advance application and understanding and education about this new genetics, but also to let people access it if they want to. And we'll tell you about how that works, even in our first test in prostate cancer. And MiraDX continues to be the diagnostic company that has the laboratory and has the staff and the people to do this all and ultimately argue with insurance to try to get things covered for patients. So we really do both. And it's been great for me. I hope it's a proof of principle and it works. So every company will do that, but I'm not going to count on it. But it works for us. Okay, so what do we study? And I'll show you a graphic of this on the next page, but a couple words about it. So as I mentioned, we're looking at your DNA. So every cell in your body has the same DNA. DNA was discovered in the 1950s. And we know from the DNA is like the textbook, how to be you. And it's a mix of DNA from your mom and your dad. They each give you half of a copy of theirs. And we've known about DNA for a long time. And we used to think we just use a really tiny sliver of the DNA. Turns out there's new discoveries, and that's not true. So what we study at MiraDX and what I've been studying for the last 20 years, wow, that's a long time, are the areas of the DNA that they were really recently discovered. The first example was in 1999. Sounds like a long time ago, but that discovery actually Frank Slack made. They're called microRNAs. And his boss got the Nobel Prize for that just this year. So the areas that we study of the DNA, they're called non-coding RNAs or microRNAs. And it turns out those are the areas that really tell you how to first develop into a person, but also manage how you respond to treatment. And I'll tell you a little bit more about that. But yeah, I think it's easy to understand why that could really matter. I was trying to understand why two people would respond so differently and their tumors look the same. But this is an explanation or a way you can individually respond. This network of this part of the DNA, everyone has little differences in it. And those differences really impact how you might respond to a stress. And cancer treatment is, of course, a very significant stress, with radiation being one example of how we treat cancer. And this is just a picture of this in case you are more of a visual person. We have DNA. We used to think that just from the DNA, you'd make messenger RNA and make protein. And this is what they found in the 50s and 60s. And it's only 2% of all of our DNA. So around 2000, people were saying, oh, we have so much junk. We have so much junk. We only use 2% of our DNA. Of course, that was incorrect because 80% of our DNA actually is also turned from DNA to RNA, but it just doesn't turn into protein. And it turns out the first example were microRNAs, but these are the boss of all the things that turn into protein. They regulate them, they control them, they coordinate them. And these are the areas that we study, the newly discovered, newly understood parts of the DNA. And it's pretty new data, as I said, and two people just this year, last fall, got the Nobel Prize. Gary Ruvkun is Frank's boss. Frank was a postdoc in his lab at that time. Okay. What does it mean if we have this information? Historically, to find biomarkers, and you've heard of some of them, BRCA mutations in prostate cancer, even measuring PSA, those are things that a specific cancer will make, and it's by cancer type. EGFR mutations in lung cancer, HER2 mutations in breast cancer. It's something different about a tumor They used to do that based on cancer type. They'd find something different. They'd try to target it. That has been the history of how we've tried to treat cancer. And I believe, and I think our tests are beginning to show, that instead we could look at things about you in your DNA, and it could be between you and a woman with breast cancer and some guy with lung cancer and across all cancer types, but it's about you as a person, and it's a map of how you will respond to a treatment that we give you. And it could be radiation, it could be immune therapy, could be hormone therapy, and we'll be able to say, your type of person, if we give you that treatment, this is how they're going to respond. So that's my big picture belief and hope for the future. And try to remember that piece. And then someday, hopefully, I'll say, yeah, you'll say, yeah, I heard about that a long time ago. And that was right. Okay. With that background, I'm going to talk about this first test that we have that applies to prostate cancer. And I'll mention we have several other tests as well. And the first area we decided that we could focus on. So my heart's always with the cancer patient, and something that I know is a challenge, particularly as people live a longer time, if they have cancer, it's becoming more of a chronic disease, which is great. That said, it really matters if someone has very bad side effects from treatment, because then we may cure them, but we've really made the quality of life much less than it was before their cancer. And radiation, worrying about side effects from treatment is something we've done from the beginning of time. Radiation, they started giving in the early 1900s. They would radiate a whole person. It was with solid source radiation, very different than it is now. So there's been so much effort to make radiation incredibly high tech, where it's a very focused, very targeted space age machine that can really deliver the radiation very precisely in the body. That said, even with the best technology, there are still people that have side effects from radiation. And I would say, as a radiation oncologist, they are just radiosensitive, but there's absolutely no way for us to know that before they're treated. I was very hopeful, and what we've been able to show is our new understanding of the DNA. It has some really great answers for that. It can tell us, before you get any treatment, how you're going to respond. And one of the ways people respond is having bad side effects, and we can predict that. So I'm going to tell you about our ProstoX test. So this test in ProstoX, it's specifically for prostate cancer patients. It predicts late urinary side effects. But I will say that these type of genetic panels, they seem to predict side effects from radiation and other cancers as well that are similar. Breast cancer, sarcomas, head and neck cancers, and those are ongoing programs. And it isn't only radiation that we work with. We actually have a lot of great work in immune therapy. And again, we started with predicting toxicity, which is a real problem from some of those new checkpoint inhibitors. I won't go into too much, but happy to talk about it if people have questions, to help before someone gets treatment, saying, oh, you are someone that's going to have side effects from the treatment. Okay. So I'm just going to talk now a bigger picture about radiation therapy, how we give it, which is very confusing, can be very confusing, and possible side effects. So there's 3 main ways that we give radiation, really 2 main ways. So when I was a resident long ago, prostate cancer patients got 8 to 9 weeks of radiation. That's one small dose of radiation 5 days a week. It wasn't me, but someone who designed radiation decided everyone should have the weekends off, which I think that's great, for 8 to 9 weeks. So it was a really full-time commitment for people. Treatments are quick. They can be done in 15 minutes, but you need to come in for that long of time, months. And you can't take vacations in the middle. You have to go all the way through. And we call it conventionally fractionated radiation. Fractionation is about how many fractions you get. So lots of small pieces for conventional radiation. The next step was actually to say, could we speed it up a little? We'll give a little bigger dose every day, and you maybe can just come for 4 weeks. This has become fairly standard of care. Very few people make anyone come for 8 weeks now because nobody wants to do it. You could come for 4 to 5 weeks. You get a little bit more each day. And with that, let me make sure I didn't just lose everyone because I heard a beep. No, we still have people. Great. So it's not as long, but with the advances we've had in radiation, actually, we now can give radiation, and prostate cancer is one of the leading areas where we do this in really 5 to 7 treatments. And they're big doses of radiation, but we found that we really can do that safely, and they're very targeted in prostate cancer given to the prostate. So these are very standard. So SBRT, these big doses, very convenient for a patient. You only need to come in a week. Maybe that's just as good as surgery, right? You're done quickly and you feel pretty much fine during treatment versus the slower courses of 4 to 7 weeks. What are the side effects? There are a couple of significant side effects for prostate cancer patients being treated, really either with surgery or radiation. I'm going to focus on the radiation one, but there are very similar ones with surgery. And the most bothersome and the most common is urinary problems. And they can include pain, blood, just frequency, urgency, leaking, or incontinence. And they really affect quality of life. And we look at grade 2 or higher, which they just reach a threshold of frequency or how bad it is. And grade 2 is usually considered significant and really bothersome for patients. When we talk about side effects from radiation, it's probably true for surgery too. There are 2 main types. Acute, or they just happen during treatment or within a couple weeks, maybe a month after. Those resolve most of the time. They're bothersome, but you can have a short course of medicine, Flomax, and it can make it better. The more worrisome are side effects called late side effects, which sometimes people don't, they are just fine until about a year or 2 years even. And then they suddenly start really having bothersome symptoms. And we know the late side effects, they were set off when someone got radiation, but we can't see it happening. So it is smoldering, I would say, behind the scene until it reaches a point where it's really bothersome. And it is very hard to make those side effects go away because I believe it's a scarring process. The risk of grade 2 or higher, so significant urinary side effects from treatment for prostate cancer with radiation can be 15 to 20%. And it's at the higher end for people that get the big doses of radiation, the SBRT. The rate is still about 15%, even if you get the slower doses of radiation. So it's not like that's safer for everyone. It's not as if the big doses are bad for everyone. It depends on the person. So I'll show you the data about that. So what's interesting is that we actually found when we first checked these new DNA markers in prostate cancer patients, we looked at patients that were treated with 5 days, a clinical trial of those patients. We also looked at a group of patients that got treated with 6 weeks, conventional fractionation. What we found was that we could predict late urinary toxicity in both groups, but the genetic differences we measured, they were different. So people that would have side effects to 5 days were not the same ones that would have side effects to 6 weeks, and vice versa, and which I show you here. There's a group where they're high risk to just the 5 days, but they're fine to get the 5 or 6 weeks. And there are people where 5 to 6 weeks isn't good, but actually 5 days is safe. Most people, one of them is safe. So almost everyone could safely get radiation and not be at an increased risk of late urinary side effects. Only about 1 to 2% of people actually will be at risk, just are radiosensitive. No matter how I give it, if I give big doses, if I give small doses, 1 to 2% of people, their body, their prostate, whatever I'm treating just doesn't like radiation, and they may be better served by surgery or an alternative. So the ProstoX test, as I've referred to, is a test of your DNA. The great thing is it's DNA that doesn't change. You have these parts of the DNA we test, you're born with them. They don't change during life. They're not different in your tumor. They're present. That difference in your DNA is in every cell you have. So it's very easy to test. You can test that DNA from just a cheek swab. So rubbing a cotton swab on your cheek with a special kit. And we can look at that DNA and we can predict if you are at risk of late urinary side effects from radiation for prostate cancer, either with a 5-day course or the 5-week course. And you can do it at any time. So certainly you should do it before radiation. And I feel like that's a really important thing for patients, just giving information that can help them and their doctors talk about it and think about it. And the great thing is with prostate cancer, you have several choices for treatment. So you could do it quick, you could do it slower with radiation, you could not have radiation at all. So I think that's prevention by knowledge. And there's been a lot of studies behind this. I know we have some physicians in the crowd, so I will mention where we started and where we're going and where we are. We started with a study, as I mentioned, that looked at 2 clinical trials, one of 5 days, one of 5 weeks. We found the genetic signatures. We did a prospective utility study, actually ended in 2022, and it's just finishing its follow-up, where we told patients and their doctors, this was just patients getting the 5-day SBRT, if they were at high risk or not, to see what do you do with that information. Not surprisingly, most patients did not want to get it if it was increased, if they were at increased risk of side effects. There are, instead of being 15 to 20% risk of side effects, if you're high risk, your risk is about 80% of side effects, so very high. So patients didn't want to do that, and doctors quickly saw it was true and didn't want to do that as well. We've checked this out in the post-operative setting, as many of you probably know. Sometimes people have prostatectomy, the removal of prostate, and they still do need radiation. And at UCLA, we have studies where we try to do it in 5 days, that radiation, and we could see that the genetics predicting toxicity when you had radiation first in 5 days are very similar to if we try to do that after surgery. And then we recently published an additional independent validation study that was looking at the fanciest ways you can give radiation, MRI guidance versus CT guidance, but very carefully delivered. And we were able to see that we still predicted side effects to the late grade 2 toxicity, to SBRT, even with the best, most cutting edge techniques, because it's a lot of those improvements in our technology help us target the prostate better. But this is really about the sensitivity of that prostate tissue, I would say. What else? So who's a candidate for the test? Someone who has prostate cancer and is considering radiation that hasn't been previously treated to the prostate before. And there are a few different ways to get this test. As I mentioned, there's through MiriDx. We have physicians that are ordering the test at this point for the last, I'd say actually 3 years. We had opened this up for different leading physicians, radiation oncologists. How would you use this test? Is it helpful? Is it useful? Try it on your patients, discuss it with them. There's no charge to anybody. We have tested almost 3,500 patients doing that through that program, and actually are just getting up and running with insurance. So we will begin billing with very generous financial assistance and a cap on any patient responsibility through physician ordering. And while that's been happening, we have also been running a study through MariKind, the nonprofit, to be sure that patients who maybe aren't seeing one of our early access doctors could still access ProstoX if it's something they wanted to do. But we ask that if you do that, that you join a study, because patients always have the best information to tell us. And so we follow up to ask questions. How was it useful? What did you do with information? Things like that. So that's an ongoing study in MariKind. We have several big centers that do work with us, which is great. And you might wonder, what does it really mean to be tested? As I mentioned, there's a way to get your DNA. It's just a simple cheek swab. You send that back, it comes to the lab, pretty high tech, the lab. There's big liquid handling machines. They take the DNA out of it, know it's your sample. They put that into a bunch of wells to test a bunch of our markers. They run on PCR machines. Then this goes into an algorithm, all the results from your sample. And that algorithm can look at literally 1 billion different endpoints for toxicity, but we keep it simple. And the report is someone is high risk or low risk. for toxicity. And I can show you what that report looks like. This is a low risk report. There's a simple graphic just telling you that you are low risk, and then your risk is 5% of late toxicity. If you're high risk, it's more like 80%. This would be if you just got a test for what we call the SBRT test, ProstoX Ultra. Sometimes people get both because they don't know what treatment they're going to get. And so they could be high risk to one and low risk to the other. That is, if you are high risk to one, there's a 90% chance you will be low risk to the other form of radiation. So it commonly looks like this, or you could be low risk to ultra and high risk to CFRT. Often, many people would be low risk to both. All right. So that was my hopefully not too fast whirlwind. And I guess I could stop sharing my screen, but I'm happy to take questions, answer any general questions.
Yes, I will go down the line here, and we're going to start with Dr. Metzger. Hi, Dr. Metzger.
Hi.
Hi, Dr.
Am I muted?
Nope.
No, you're loud and
Okay.
clear.
Thank you. That is really excellent talk. It's really reassuring to know that this kind of stuff is on the horizon. Could you just comment one more time? We're seeing a lot of guys that have had radical prostates. And even though we have some of the best surgeons in the world in Southern California, PSA goes up and they need post-operative radiation treatment.
Yes.
I think I heard you say that for a rising PSA post-op, you can still predict and get the SBRT.
Yeah. So at UCLA, the standard for postoperative radiation has been conventional, slower fractionation. Yeah, at UCLA, we've done a few trials of giving the 5 days, even a post-op setting, and it seems to be able to be done safely. And we do find our signature in the SBRT setting is the same signature. So we can identify patients who would be at pretty high risk of that form of radiation. We actually have a few clinical trials coming in to confirm that in a regular conventional radiation schedule, the same thing works in the post-op setting. So that has to be validated still, but we actually have a few groups that are working with us on that.
Fantastic. And the other thing, I just wondered if you comment, it's a little bit off the subject, but you mentioned MRI guided, CT guided. Do you think PSMA guided is going to make a significant difference, or is it just another minor advance?
No, I think PSMA is really significant, particularly in identifying people with very limited metastatic disease, which if we couldn't see it, we'd never know. And it's so tricky in prostate because someone's PSA goes up and we don't know if the prostate, they failed in the prostate bed, they failed in the prostate, or they have a small bone mat somewhere. So PSA is really an amazing technology to a PSMA scan to be able to see that. And we have numerous studies going on at UCLA where we actually combine radiation to the prostate and to maybe those spots with some additional therapy, like a lutetium type of driven therapy, and really see great outcomes. So I think it's the knowledge. I think it's a huge advance, PSMA scans.
I just want to end my part with complimenting your department down there. You guys got a world-class group of folks, and we really appreciate their efforts for us and the efforts for our patients. So thank you.
Awesome. Thank you.
I'm going to hop around a little bit. Francis, I know you have a question. Would you unmute and ask your question, please?
Oh,
Still-
muted.
There we go. Hi, doctor. Thanks for a lovely presentation. I did put my question in chat box, but it's probably just as quick for you to read it as it is for me to.
Yes, I'm looking. Oh, I'm going to look at this. So you are high risk on that test?
Yes. Daniel said that's the most difficult telephone call that she makes.
Oh, hates that. I know. When someone's high risk. The question is in the radiation process for me, other than just the radiation dosage, the radiation technology different. It's still very high tech and very delivered. It's just they offer you moderate hypofractionation. So it's the 4-week course and people do great with that. And it's still MRI guided. It's still excellent and targeted. And you'll be a pretty low risk of toxicity.
Okay, so everything other than the fact of the number of days,
Yeah.
great.
Yep. You just get to visit us more.
Oh boy.
We're so nice. Actually, I treat breast cancer in my patients that are done in 5 days. I feel like I barely get to see them. I enjoy my 4-week patients.
I'm going to be missing Southern Oregon for 4 weeks and staying down there with you.
Oh, yeah, that's probably hard. Is it get cold and rainy in February? Maybe you should come then.
There's a thought. Thank you, Doctor.
Sure.
Brian, you usually have some great questions. Would you unmute and share your thoughts with us?
I'm simply very grateful. Doctor is my hero. He did the SBRT. Obviously, no, I hadn't got the ProstoX test, but I think I'm contributing data to Danielle and your databases as
Probably.
this is the great end over here because I have very little to complain about. It basically says if you're good on the test, and sorry about that, Francis, if the test shows good, this is the way to go. So,
Good.
Candidly, Brian, I have to say, and I've talked with my wife about this, better to know now than 12 months from now.
That's the thing.
Yeah.
To be able to make the choice when it makes a difference, if you make it. I totally agree.
I've got enough problems with a history of bladder cancer and frequency and nocturia and all that I don't want to add to that.
right.
Oh, yeah.
While we're on, just since you have my voice here, I want to say thank you very much to, is it Kyle or Kylie?
Kyle. Hello.
Hello. You have been wonderful in helping arrange all of this. So I really
good.
appreciate the
Well,
help
likewise, you've been great to work with too.
because we're delighted to have Dr. Weidhaas here. Back to you, Neil, then.
Bob from New Jersey, how are you doing?
Hi,
I
Bob.
am fine. Thank you. Great talk, Doctor. And I'm glad you mentioned this test applies also to post-prostatectomy down the road where you have recurrence. One question, you seem to be talking about toxicity to urinary issues. How I'm not familiar with how you define that. I've heard people talking about issues, intestinal, rectal, stuff like that. Does this apply to that also, or is it strictly bladder related?
Great question. Actually, it is not. It does not predict bowel toxicity, which is a different signature. We see much less of that, particularly since they use the spacer or also pre-delivery imaging for MRI guided. So we don't see as much of it. So we're waiting to build those data sets. But fortunately, because of some technical things, they've been able to decrease the bowel toxicity a lot. That's a little bit of an off target. We don't want to hit the bowel. Tox is the urinary side effects. We really think is about just treating the prostate because we think it's fibrosis of the prostate around the urethra that is causing the symptoms or part of the symptom. Yeah, no. So ours is just about that urinary toxicity.
Okay. My focus, I haven't done any post-surgery radiation. I'm in recurrence without detectable lesions on a PSMA PET. So I'm basically waiting until they find something. But so the PET spacer doesn't apply once your prostate's gone and they want to radiate, let's say, the prostate bed.
Right. That's correct.
But okay. So this is part, but it isn't all encompassing yet.
Doesn't cover everything yet. It doesn't cover everything yet.
Okay.
I know. Lots to do.
Okay. I hope that happens down the road.
Yes, we're working on it.
Great. I'm going to pop around a little bit, folks, so don't be patient with me. I will get to you. Ira, good evening.
Good evening. First, thank you, Dr. Kyle, for everything you're doing at your organization. At our support group, there's just far too many people who come and they have to stop treatment halfway through. So thank you for what you're doing. Could you talk to the difference between ProstoX and radiogenetics? How do each of them work?
So radiogenomics, different?
Genomics.
Yeah, they call it different things. So there's radiomics, which is a field of study where it's actually trying to look at imaging and seeing if that correlates with response. They don't look at toxicity as much. It's more looking at tumor response. And a lot of that's imaging based, like the pictures they take every day, MRI, CT guided imaging, that's radiomics. ProstoX is a genetic test, although it's the only one really testing this part of the DNA. No one else is quite looking at that part. And then genetic testing that people might get is they're looking at some of the 2%, the protein parts, which include things like BRCA, which is, or ATM, which they might look at for, it's not uncommon and it's really rare, but people with prostate cancer, more advanced prostate cancer, are the chance they may have one of those mutations is more common. If
And
I answered.
so for ProstoX, it's a slightly different question. So have you had clinical trials, and what was that?
Yeah, so we did. So we had several studies. Some have been looking at a retrospective analysis of prospective studies where they collected all the data about how people did. We also did what's called a utility study, where before treatment, we gave the information. This was the first prospective study we did on it. We shared with the doctor and their patient, this is your results, and to see how they would do, with the goal, with the hope that if they followed the advice of the test, that if you're high risk, you don't get SBRT, overall the group would have less toxicity. So that the final analysis of that is coming out later this year. And then we checked in the post-op setting, and then we had another study that was again, a prospective study. We did a retrospective analysis of it and saw that it held up again. And then we have a few other big clinical trials that we have in-house that we're testing as well.
Okay, thank you.
Sure.
Good luck with your organization. So people can come from other institutions and contact UCLA for the test, or your organization for the test? Is that what happens?
Yeah, so a lot of times we have doctors at several organizations around the country. So
Right, I
NYU,
saw a listing on the bottom
yeah,
of one of the
lots of places.
slides.
So there's those doctors. And then through the nonprofit Mere Kind, patients can join the study to get the testing. There's a cost to that. It's not free like it is through the doctors, although we will start billing insurance as well. There'll still be limited costs for patients. That's the goal. So, or the plan. So there are a couple avenues at this point.
Okay. Once again, thank you for what you're doing.
Sure, my pleasure. Thanks.
I'm going to pop around, guys, but I'll get to all of you. Marshall, how are you doing tonight? Would you like to unmute yourself and ask a question?
No, Neil, I don't have any questions. Thank you.
You're welcome. Greg, welcome back. Greg Rep, can we answer any of your questions tonight?
Thank you, doctor, for that presentation. It was very enlightening. I have I just had my consultation at City of Hope with a medical oncologist this week, and I have now a consultation with their radiation people next week. Is that within the network of people that you're working with?
I've spoken to them. They asked about getting the test, but Kyle could tell you more.
Yeah, they're not one of our partners yet, but we're happy to talk with any of the physicians there if they want to learn more. They would get your test results, but we're happy to educate them if they are interested.
I think they know of it though, because they did reach out. We did talk to them at least once, I think.
Yeah.
Okay. But certainly based on the results you were seeing, it sounds like something that if I end up choosing the radiation path, it's some information that I think would be really relevant. So,
Yes.
and how soon do you think you'll be actually just billing insurance like anything else?
Soon, really, our goal is September 11th. It goes live. Yep.
Oh, okay.
Yeah. So at that point, we'll really allow all physicians to order and put that through, and we'll fight the fight and probably not be paid anything for a while, but that's okay.
Thank you.
Yeah, of course.
All on the blue screen. How are you doing tonight? Can we answer any of your questions?
I'm doing good in terms of hearing a very good presentation. I appreciate it, doctor. I'm doing bad because I did take the ProstoX tests, both of them, through your chart organization, and they both came back high risk.
Ugh.
And you just said that it's very unlikely that we will both be high risk. So
It is rare. You're like 1 to 2% of people.
So I have this, based on this, no matter which I do, I have an 80% chance of getting these severe after effects. Is that correct?
Generally, I'm happy to look at the results for you if you want to reach out and we could see maybe one is lower than the other. Sometimes they do it that way. We have people that are trying. We don't know what it means for different types of brachytherapy. At low dose rate brachytherapy, if that's an option for you, I don't think that's the same because that's a very different biological response. I have say high dose rate brachytherapy. I do think it's pretty similar to SBRT. So there could be options. I know sometimes they try once a week treatment depending on the scenario, but I'm happy for you to reach out to me directly. I'm happy to just share what people do.
And so brachytherapy, that's the seed implants.
Yeah, a permanent seed implant. We're doing a study to see if that's a completely different signature than conventional, but biologically, it's a much lower, slower dose delivery, and it could be different. So that may still be safe for you in the right hands.
Okay, that's up in the air still.
Yeah, we haven't tested it. We haven't tested that yet. We have a cohort. We have patients being sent in by group on the East Coast where they do a lot of permanent seed implants to really test to see if we have a signature predicting or if it's just totally different.
Do they do brachytherapy at UCLA?
We do a lot of it, but they tend to do high dose rate. I don't know if they do the permanent seed implants. I could ask someone actually. At the high dose rate where they just get big doses, usually just 2 times, that's pretty similar to the SBRT.
Right.
I wouldn't necessarily recommend that path.
Okay, it is what it is. I thank you very much for the information.
Paul, if you want to get in touch with the doctor, you can find her. Google Joanne Weidhaas, and she has her own at UCLA. You'll probably also find it in our announcement. Her
Yeah,
contact.
he'll reach out.
Okay.
So
I don't want-
there and reach out either by email or phone.
That's
Tim, welcome. And can we answer any questions for you? Tim Rigby.
Thank you. No questions, just learning. Appreciate all the info.
Thank you for attending, Tim.
Thank you.
Michael's iPhone. How are you doing tonight? Can we answer any of your questions?
Sorry, had trouble unmuting. One of my questions was answered about brachy. Does the test also apply to proton beam radiation?
It really does. So protons, they're a little bit different, but they haven't really been proven to be better in any way, but they maybe keep it really focused. But we think it's the prostate itself. Yes, it is being used by several clinics that do protons, and it seems to be the same. Protons, they don't usually do SBRT. They tend to do the slower course, the 4 to 6 weeks. And so it's that signature for protons. That is the predictive one.
Did that help, Michael? Oh, you're muted again.
Yes, hopefully.
We can circle back, Michael. Steve has been a longtime supporter of Prostate Forum with his participation. Welcome back, Steve.
Hi. Yes, I was. If I heard you right, you said you can't have previous radiation to take those tests.
To the prostate, and I don't think we usually retreat the prostate anyways. I just don't know how predictive it would be if it was a second radiation to the prostate, but I think that's unusual. So they don't generally treat that way for prostate.
Okay. Thank you.
Sure.
Lal, how are you doing tonight? I know you have questions.
The only question I have is the difference. I put the question up there. Is your radiation, regular radiation, and SBRT cancer prostatitis? Because that's what I have.
What are the risks for prostatitis with regular versus SBRT?
or your system that I think your system is SBRT.
We do both. At UCLA, they do a lot of SBRT, but we have a test for both. And then the chance of toxicity just for everyone without a test is 15%, 15 to 20% risk of prostatitis. Our test, if you're low risk, that risk is more like 5% for either of them, SBRT or 4 to 6 weeks. And if you're high risk, is about 75 to 80%.
So why do you say the risk of that person should be the risk of the treatment?
Yeah, it's for that person. It's the risk from the treatment for that person.
So how does that differentiate between person to person?
Yeah, we're looking at your own genetics. So we're trying to see. So if they take 100 patients in the past and they gave them radiation, they'd find 15 to 20 would have bad side effects, but we didn't know who they would be. So now we do this test to try to separate you into someone that is more likely to have bad side effects or someone that's less likely to have side effects based on your own DNA, your own genetics. So that's what the tests are looking at. So it's risk stratification, right? So it's putting you into a lower risk group than the average. So if before we just tell people it's 15 to 20%. Now we can be like, oh, for 85% of you, it's only 5%. For 15% of you, it's 80%. So we've separated you into different corrals, different buckets. I don't know.
So you are doing a DNA test now before you start the treatment?
Yes, exactly.
Thank you.
Sure.
Are there any other questions, ladies and gentlemen? I got a Craig Rep question, and we're going to circle back to Michael's iPhone. Craig, why don't you go ahead, and I'm going to circle back to Mike.
All right. I'm just thinking about the 5 or 10%.
Yeah.
End up having issues, even though their risk was considered low. Do the effects, are they the same?
You know,
Do they
they
have the
seem to be a little less. They're not as bad. So the people that still do that we said were low risk, depending on the grading system, you can be called grade 2 just by going on Flomax. And some people are on Flomax anyways, just because they have an enlarged prostate. So that's some of the grayness. We almost never see like a grade 3 or serious side effects for someone that's low risk. We just almost never ever see it, at least in the cohorts we've tested. So I'd say it's been shifted anyways. You might have a grade 1 and maybe go on Flomax, so they call you a grade 2, but they're usually pretty mild for someone that's low risk. That's what we've seen.
Thank you, doctor.
Sure.
Michael, let's get back to you, Michael's iPhone.
Yes, my first question was answered. What is the likelihood of being placed in the wrong group? The false positive or negative if you were doing a dichotomous grouping?
Yeah, so there's a positive predictive, negative predictive value. I'm trying to think of which. The specificity is about 0.8. So that means we'll miss 20% of people that we call high risk. It's not 100% foolproof, the test. So that's why 5 to 10%, 5 to 7% of people that are low risk might still have toxicity. So they were misclassified. And for the high risk group, about 80% of people will have toxicity. So 20% of people didn't have toxicity that we called high risk. Although many of those people were not giving them SBRT, actually, most of the high risk people. But sometimes it's a matter of time, or sometimes we're going back through actually a study that we're presenting in September. We looked at the first 150 people that we told were high risk to see what did they do. And some percent of them still got SBRT because it was from the beginning of time we started this test, and we followed them. And then 80% of people didn't get SBRT, and we followed them to say, how safe was it if you didn't get SBRT? How bad was it if you got SBRT? Now, none of them, the people that got SBRT and they were high risk, a lot of them have toxicity. It's about 85% do have toxicity. The other ones, maybe by 5 years out, they will. We're just following 2 years out. I hope we're wrong and they don't have toxicity, but they are really high risk compared to the people we say are low risk. Yeah, we
Thank you so
get better. Yeah, as we expand our genetics and our population, we'll pick up other rare things that someone might have that put them at high risk, that just there were so few people like them in our first cohorts. But our hope is we constantly look to see if we can improve the signature. to be a little more perfect. It would be
Right.
we are 100.
Thank you so much.
Also, sure.
Outstanding. A question I have for you.
Yes.
I would imagine Kaiser Permanente would love to do this test as something economical that could save patients a lot of trouble down the line and actually allow them to practice medicine much more economically by not cleaning up side effects down the line.
We think so too. And we have tried to talk to them a couple times, but it's really tricky to figure out how to present to the right people. But hopefully we'll keep on trying to do that, actually. I can't remember where we left all those conversations off, God, but it seems like a no-brainer to me because they're an integrated system. So they're saving themselves money. You have to get into the right people at the big organization.
It seems that they're organized according to whoever the regional chief of urology,
Yeah, I do think.
regional chief of radiation. So in Anaheim, we would know some people in Anaheim, and then they're changing around. So that makes it harder too.
Yeah.
But it's organized more on a regional level.
That's what we were. You have to find somebody that will fight in an area for you to get in front of the right people. You can't just, we had someone really trying to figure out who to talk to, but I think that's correct. I think it's more regional. We're always happy to talk to anybody.
Outstanding. We have a few more minutes. Oh, Bob from New Jersey. Hi, Bob.
Hi. One more question.
Yes.
In a recurrent scenario, if they do find spot or spots like oligometastatic, and if one of those spots is, for example, in the prostate bed, would this test be useful to see, again, treating a spot there, not broad-based? Would this test be useful to do before any treatment?
So we believe the SBRT test is if you're going to get SBRT. That is not a common way that it's treated in the post-op setting. And we still are testing if our other test for the 4 to 6 weeks is the same in the post-op setting. I hope to have that information. I'd say definitely by the end of the year, if we have a few data sets we're waiting on to come in.
Okay. We'll see. Thank you again.
Anybody else?
Neil and Doctor, I'm just curious, as the biologist in you, what's the evolutionary relevance of this radiation sensitivity? I know it's speculative, but do you have any guesses?
It's so speculative. I think that our wiring for microRNAs, the first marker we found, which disrupts KRAS, it actually leads to a very kind of suppressed inflammatory reaction. I'm like, maybe people survived like a plague where people just died of inflammation in the lungs, right? There may have been selective pressures. The differences we study are only found in humans, and partly because these new parts of the DNA are much more expansive in humans than in smaller animals. I don't know. That's very curious how they work and why, but a lot of them, we study markers that are fairly well maintained in at least 5% of people. So there probably at some point was some selective advantage for them.
It's fun to think about.
Yeah, that's super fun to think about.
Thank you.
Here.
You just took us somewhere else, and that's in another emerging area of cancer research, and that's the role of inflammation.
Or one other.
Sorry, 1 second.
No worries.
My son that's his ringtone.
No, you just took us into another area that's emerging, and that's the role of inflammation in cancer research and health generally. And that's growing.
Definitely. The immune system, all of that is really interesting.
You've given us other paths to take in future presentations.
Sure. Happy to do it.
I want to make a last call for questions. Any questions at all, ladies and gentlemen? I want to make a shameless plug for the prostate forum. If you're watching this on YouTube, keep in mind that we serve men with prostate cancer and their families at all phases of the disease, from diagnostics through side effects. You can find us at www.prostateforum as one word.org. Prostateforum as one word.org. Check us out on your website. browse the website, you're going to find this presentation in our presentations and videos going back years, and a lot more. Dr. Metzger writes an outstanding weekly newsletter, goes through, you're going to find cutting edge stuff long before it hits the books on prostate cancer. We certainly benefit from your donations. If you have benefited from what we have done, we would be grateful to accept a check, even a small check, to 1519 East Chapman Avenue, Box 380, Fullerton, California, 92831 here in the United States. If I move too fast for you, you'll find our address and donation information on our website. Doctor, thank you, and we look forward. Please keep us apprised of how this is going and growing. This is a fascinating area and very important to us, and we look forward to having you.
Of course. My pleasure. It was super nice meeting you all. Thanks for the great questions and attention.
Thanks kindly.
Thank
Thank
you.
you.
Mayor.
Bye-bye.
I wish you all a good evening, and check us out at prostateforum.org.
Bye.